Good evening, everybody. This is Dr. Rick Lehman from St. Louis, Missouri. This is In Your Corner with CORA, 9/9/2020. And tonight we're talking about distal biceps tendon tears as relates to football injuries. And actually, it's an injury, as a sports guy, I actually see not infrequently during football season, which of course right now is a little bit on hold. We're looking at the NFL, we're looking at the SEC, and it looks like we're going to get started maybe a little bit late, but football, I believe, will happen. So we'll see these distal biceps tendon injuries. Adam, go ahead and introduce yourself.
Yeah, I'm Adam Prather. I'm a physical therapist and clinic manager of CORA Physical Therapy in Somerset, Kentucky. And been there for about 4 years and like to work with the local high school. So I do see some football players from time to time.
That's great. Dr. Pinn?
Sure. Hi, my name is Dr. Pinn. You can go by Dr. Pinn. I'm a shoulder elbow surgeon here with the Signature Orthopedic Group in St. Louis, Missouri. And we take care of primarily, shoulder and elbow patients.
That's great. So let's just jump right in. Distal biceps tendon injuries, pretty specific injury. And Dr. Pinn, why don't you start off and explain the anatomy of the insertion or the anatomy of the biceps in general and the insertion of the biceps as it relates to the elbow?
Sure. So the muscle belly of the bicep starts in the anterior compartment of the arm and then goes down past the antecubital fossa and it inserts onto the radial tuberosity. And it's the biggest supinator of the forearm. And the way that it attaches, the radial tuberosity has two components where the long head attaches and the short head attaches. And the short head attaches a little bit more distal and the long head attaches more proximal. And then in addition to that, the radial tuberosity is actually more of a dorsal structure. So that's something that we talk about in terms of being able to restore supination and restoring the tendon back to where it came from during the operation.
That's great. Thank you. And Adam, why don't you tell us about football injuries and tell us about the mechanism of injury? How does college football player, NFL football player tear their distal biceps? And then maybe extrapolate a little bit how Mr. Jones, garden variety patient in the gym, maybe tears their distal biceps. What's the mechanism of injury?
Yeah, usually you're looking at some kind of load overpowering the elbow, whether they're trying to pick somebody up and it's getting pushed down or even the arm being pulled behind them. What I mostly see in the clinic, I don't see a lot of bicep tears from football players, but I've seen a lot of people that they were falling, reached out, grabbed something, and a pretty quick force yanked on the elbow. Or somebody who was lifting something too heavy. Actually my father was lifting a calf up into a trailer and on our farm, and it kicked and just ripped the distal bicep right off. And I'm in the weight room quite a bit, which you would also see with some football players, but if they're getting into doing like some mixed grip deadlift, you got to be really careful. That's probably the most common way in the weightlifting room to see a bicep kind of tear off like that.
Great, thank you. I had an interesting case probably about, 4 or 5 years ago. It was an NFL running back. He bet a guy, I think there might have been alcohol involved, I'm not sure, that he could lift the end up of a car. It was a Volkswagen, and he bet the guy, I think, $500 he could lift the end of the Volkswagen and tore actually both his biceps tendons. So that's right. It's usually a fairly aggressive force, and generally you hear a pop, and there's really not much question about the diagnosis. So Adam, why don't you tell us what the prehab is? Somebody comes in, they see Dr. Pinn, they've been diagnosed with a distal biceps tendon tear. Dr. Pinn tells them whatever he's going to tell us, he's going to tell them here in a minute. And he sends them over to you and he says, look, I want to get this patient possibly ready for surgery. What is the prehab? How do you treat that patient prior to any surgery, any other treatment?
First off, we're going to try to focus on everything that we can strengthen, within, respect to their pain. And maybe the most important thing is making sure that they have full range of motion going into surgery, full elbow extension and flexion. And then if it's a full tear, it's going to be a little bit hard to strengthen that bicep, obviously. But if it's a partial tear, trying to strengthen it very lightly and pain-free.
Great. And Dr. Pinn, so they had their prehab. They come in to see you. What do you explain what you go through, your physical exam, and what your recommendation would be for somebody 25 years old, they've torn their distal biceps, kind of go through how you make the diagnosis. Do you get an MRI? Tell us about the hook test, and then tell us what you're going to tell that patient in terms of treatment or options for treatment. I'm sorry.
No problem. So the big thing from the history that I'm trying to discern is whether this tendon was healthy before and then it was a degenerative tendon that tore. And so I usually ask patients if they've had pain in around the distal biceps or biceps tendonitis prior to it. If they had some sort of partial tear that then became a complete tear. If they had this degenerative tendon because of, smoking or, steroids, and then subsequently, tore their tendon versus a football player or a weightlifter that had acute tear. So I want to discern that from the history. On the physical exam, the hook test is one of the most sensitive and specific tests for a distal biceps rupture. It can fool you because sometimes the lacertus can actually be intact, or you can have a tear that's a partial tear involving just the short head or the long head. It can confuse you. So you have to make sure that in addition to the hook test, you can also check forearm supination and strength in forearm supination. And it's more forearm supination than flexion because there's other flexors that are stronger than the biceps, like the brachialis. So really, the bicep should be tested in terms of how much supination that you have. And so when I see these patients, I think in the way that I think about biceps ruptures is in terms of indicating it for surgery is you're basically indicated for surgery if you're young and healthy, and the only people that I would consider non-operative care for are older, low demand, sedentary patients. And sometimes if patients are willing to accept, we know from the data that you lose about 50% of your, supination strength and your sustained supination strength. So if they're willing to accept that, that's something I would consider as well, treating them non-operatively. But in most patients, this is an operative case.
So what kind of problems are they going to have if you treat it conservatively or they decide not to have surgery? Screwing in a screw, there's definitely an endurance factor, and you're 100% right. Supination, as you said, the literature says you lose about 50% of your supination. So what kind of things, so the patient comes in, he goes, well, Dr. Pinn, what can I do? What can I do and what can I do if I don't have it fixed? Why should I have it fixed?
Yeah, so I would tell them that they would have weak, like you mentioned, 50% supination strength loss. So with activities like opening doors, using a screwdriver, and even things like where you're holding things in your hands with your arms supinated. So those are the activities that I would tell them that they would have a hard time with.
And in terms of the surgical treatment, the literature tells us there's sort of the single incision, there's a 2-incision technique. Could you describe for us what does all that mean? Yeah,
so the single incision technique is essentially, about a 2-centimeter incision in the front of the arm, and then you go through an internervous plane, get to the radial tuberosity, and reattach the tendon back down to the radial tuberosity. The 2-incision technique is you make a smaller incision in the front, you identify, you mobilize the tendon, and then you attach it through a posterior incision through drill holes and tie it over the top. And so initially, before I would say modern implants, you would have to do a more extensive dissection for the anterior approach, single incision, in order to create more drill holes. And so the thought was when you have 2 incisions, you can make a smaller anterior incision and avoid the radial nerve and the PIN nerve, which is pretty close, and taking down the recurrent radial artery branches of it. So, but over time, I would say that most people now do a single incision technique because of modern implants and using endo buttons and interference screws or whatever technique that you like. Having said that, the other advantage of having a dual incision technique is that you can really get around the back of the radial tuberosity. And like I mentioned earlier, a lot of that tuberosity is on the dorsal aspect of the radius, and really you're supinating the arm significantly when you're attaching the tendon. So if you don't have to supinate as much when you're using a 2-incision technique. So those are kind of the 2-incision versus the single incision.
And when the patient asks you about the complications, if you use a single incision or you use 2 incisions, what are the relative complications? You talked about the posterior interosseous nerve and the radial nerve a little bit, but explain kind of the complications for the two procedures, especially for the therapists out there who might be evaluating these patients in the clinic. What are they to look for early and then late in terms of HO or other problems that may occur?
Sure. So when I think of the 1-incision technique, I think of a bigger anterior incision, and you have to move more things out of the way. And there are a number of things in the way. For example, you have the lateral antebrachial cutaneous nerve, which provides sensation to the volar lateral forearm. And then you have the radial nerve and the PIN nerve, which goes around the radial neck, which is also in pretty close proximity. So that is responsible for wrist extension, thumbs up, EPL, and also extension of your first finger with the EIP, which is the last branch. So those are things that I look for in my post-operative patients, but also ask the physical therapist to document is wrist extension, thumbs up, if they have numbness in the lateral forearm. And then a later complication with the 2-incision technique include synostosis or heterotropic ossification. And so as you go through therapy, that's something you should look for, is decreased range of motion and pronation, supination that you had before, and now you're losing it.
Awesome. That was really good. So Adam, Dr. Pinn just fixed Mr. Jones. And Dr. Pinn, when do you send your patient to therapy? You got done with surgery, you're talking to the family. What are you going to tell the family? A, what the patient can do early and post-op? You immobilize them. How do you go about their early post-op care? And then secondarily, when do you start their therapy?
Yeah, so I basically divide it into 3 categories. This is what I tell patients too, is the first category is you want the tendon to heal. The next category is you want to get your range of motion and then work on strengthening. And then the third category is, you resolution, or you're trying to regain your complete strength, complete motion, return to activities in sport. So I personally split my patients in 90 degrees and I start no physical therapy for the first 2 weeks. And then at the 2-week visit, I take sutures out and transition them into a brace that's locked at 90. And that's when I start physical therapy. And really the goal of the 2-week to the 6-week perspective is being able to protect the tendon, but also maintain motion. So they can work on range of motion of from 15 to 120 degrees of flexion. And then after the 6-week point, I encourage full range of motion. And I'm more confident that the tendon is healed at that point. So they can start early strengthening. And then the 3 to 5 month point, they're working on improving strength with a plan to return to sports at the 4-month point.
And what do you tell them? Do you tell them that they can return to all sports, or the patient comes in, they want to know, can they play volleyball? Can I play basketball? What do you tell them their expectations are in terms of returning to different sports?
Yeah, I would tell them that if 1, their tendon heals, 2, they gain the complete range of motion, and they're able to maintain their range of motion and achieve their preoperative strength, they'll return to all sports that they want to do. And
just a technical question for my own edification: suspension technique, endo button versus interference fit. Do you have a preference?
Yeah, I use an endo button, and then what I do is I do a whip stitch down the tendon, and then use an endo button to flip the button, and then I use a tension slide technique to sock the tendon down into the radial tuberosity.
So maybe similar to a proximal biceps tenodesis, some people would do a subpectoral kind of using that same technique.
Exactly. Yep.
So Adam, it's your turn, buddy. So Dr. Pinn just got done. He sent the patient after 2 weeks for some general physical therapy. He went from immobilization to a brace. It's 2 weeks. They walk into the clinic. Your first post-op visit, kind of walk us through the rehab. What are you going to do early on, and then how do things progress?
Yeah, so I mean, the first visit there, you know, they've been immobilized for 2 weeks. You know, depending on their age and a number of other factors, it's going to kind of determine, you know, a little bit how aggressive and what kind of outcomes you can expect. But that first visit is going to be a lot of passive range of motion and assessment. You know, seeing what kind of flexion extension they have, and then also separately supination, pronation. And as you progress the therapy, you know, you're able to kind of each week, at least what I've seen, you know, you're pushing about an extra 10 degrees, you know, so if you're starting at, say, they're 40 degrees out from full extension, the next week you'd be going for 30 and then 20. And depending on the surgeon, those numbers are going to fluctuate a little bit. I've had people come in 2 weeks out and had full extension. Now that's one of the few that I've seen, but most of the time they're 90, 80 degrees locked, and then we're working from there. So it's going to be, you know, mostly passive range of motion. As we get closer to 4 weeks, it's going to be a little bit more active assisted. Going to be using the triceps and, you know, the pronators to kind of pull into those motions. And then when we're getting closer to 6 to 8 weeks, we may start on some light isometrics. Getting closer to that 8-week range, we're going to be going to kind of some light isotonics. Making sure that nothing's painful. And, you know, once you kind of got to that 3-month mark, 12 weeks out, you know, as long as nothing's pain-free and we've gotten full range of motion by then, you know, you're kind of progressing them back into, you know, daily activities. It's going to be a little bit longer for sports-specific stuff, but that's kind of, in a nutshell, kind of how we're progressing therapy with them.
So the patient comes in, it's week 3, and they're a little bit of a gym rat, and they say, Adam, when can I go back to lifting weights? I want to start benching. I want to get on the TRX. What do you tell them? When can they get back into the routine, and how do you progress the routine?
You know, usually I'm going to let them know up front and let them know that I'm confident with what we're doing. You know, usually who I'm seeing for that is the football players, the people who are active, the weight lifters. You know, hey, we see this all the time, you know, and we've had other patients, we got them bench pressing, we got them doing assisted pull-ups, we've got them carrying stuff. You know, we're going to get to that, you know, and just let them know that, you know, around the, you know, 4 to 8 weeks, we're going to start with the light strengthening, but, you know, they're going to have to just be patient and, you know, wait till we get further on down the road and just trust the process more than anything.
Excellent. So Dr. Pinn, you're in your office. 25-year-old guy walks in. He injured his biceps about 9 months ago or a year ago. Didn't really have insurance. Now he's got insurance, and he comes in and he says, look, I'm having trouble. I'm a carpenter. I can't work. I can't use a screwdriver. I'm having trouble, just like you said, rotating. Supination is weak. My flexion's okay, but I fatigue. I'm getting some cramping. What do you do? How do you take that chronic, retracted, messed up biceps? What can you do for that patient?
So, you know, as you mentioned, the first thing I would do is I'd get an MRI to evaluate both where the tendon is and the tendon quality. Being 9 months out, you would expect it to be pretty retracted, probably to the mid-arm, distal third arm. And sometimes you can be surprised that, you know, the tendon kind of gets balled up and you can actually get a lot of length on it. However, most of the time you have to do a reconstruction if you're planning on doing you're planning on treating this operatively. And so the way that I think about it is that, you know, you have the muscle, which is atrophied a little, and you have the radial tuberosity, and you have to find a way to attach the two. And so if you can't get a tendon there, you have to replace it with some other tendon. So the tendon that I think, you know, that I use and a lot of elbow surgeons use is the Achilles tendon, using an allograft Achilles tendon. And you can split the Achilles tendon, the thin part, and weave it through the muscle and then attach to the radial tuberosity. And then in order to identify the tension length relationship, usually you do it with the arm fully supinated and with about 60 to 70 degrees of flexion.
And how does that patient do? In general, do they do as well as a primary repair, or what do you think in terms of outcomes and return to supination strength and endurance?
Yeah, I would right off the bat tell them that they probably are not going to regain 100% of their supination strength, but they probably will gain more than they have without the distal biceps being attached.
All right, Adam. So give us a pearl and any final thoughts.
Well, you know, like I said, I'll kind of go back to my dad who tore his bicep, and you know, he kind of waited too long to tell me, and about 3 months out, he was wanting to get surgery. And, you know, I kind of talked to some local surgeons. They kind of, you know, recommended not getting surgery at that point. It might be a little difficult if it's retracted. But, you know, the main thing for me is I was surprised at just how much elbow flexion strength that he had. And as far as supination strength, you know, I mean, it gives him some trouble, but he actually did fairly well, you know, for being over 60 years old and working on a farm. You know, I was surprised at how well, you know, he was able to do non-operatively with a full rupture there.
And let me ask you about the cosmesis of that. So he's got his shirt off. You're looking at his arm. Does his arm look like his other arm, or what does his arm look like?
You know, he's got the, you know, a little bit of the Popeye deformity there, where you're seeing it kind of rolled up. But at least for him, it's really not that noticeable. Maybe he's lost too much of the other bicep. I don't know. But, you know, it's for most people, it's going to be an obvious defect, I think, you know, for someone who's decently toned. So.
Great. Dr. Pinn, give us a pearl and any thoughts. What have we missed, and what should we discuss or tell our physical therapists and physicians out there about the distal biceps?
Yeah, so in terms of diagnosis, I think an eccentric load with arm flex is what usually causes a complete biceps rupture. And then I think that most patients that are active should get treated operatively, whether through 1 incision or 2 incision. And then for rehab, most of the time you stay out of the joint when you do this procedure. You're not really in the joint. So I'm not as worried about stiffness after surgery. There's not many patients that get super stiff after a distal biceps rupture. And so what I'm more worried about is the tendon healing. And so really getting and maintaining range of motion while the tendon's healing is my biggest priority during the physical therapy phase. And then after that tendon heals, then you can work on strengthening. But if I were to err one way or the other, it's to let the tendon heal before working on strengthening or any sort of a range of motion.
And do you think biologics play any role in post-op healing at 4 or 6 weeks? Is there any evidence to suggest PRP or PRP amniotic stem cell combination or any stem cell combination with a biologic enhances healing?
You know, I don't think there's any great data supporting any specific biologic helping. So I personally don't add anything when I do a distal biceps repair.
And then one last question. Please explain the cosmesis for someone who's had no surgery, they've treated conservatively, somebody who's had an acute repair, and somebody who's had a delayed reconstruction. What's that elbow look like? What's the biceps, the length of the biceps look like, and what's the cosmesis look like?
Yeah, so as we talked about earlier with the Popeye deformity, these patients present acutely with a Popeye deformity, especially the big males with big biceps and big arms. They have a very pronounced Popeye deformity. And that gets slightly better over time if this was treated non-operatively because the biceps muscle belly atrophies, but you still have that Popeye deformity. usually after, if you repaired it acutely, you're able to restore some of that deformity and cosmesis. But in a chronic situation where you're doing a chronic reconstruction, oftentimes you're unable to help with the cosmesis, and you're really doing it for supination power.
Thank you very much. So you guys were great, and I just want to thank Adam, Dr. Pinn. This was a very informative CORA. It's not a real common injury. I mean, a shoulder and elbow guy, a sports guy, is going to see it on a routine basis. You're not going to see it like a rotator cuff tear or an instability pattern, but you're going to see it, and you're going to see it consistently. And I think the rehab is very important. I think if your goal is to get your supination strength back, sending guys home with exercises has not been fruitful. I've had some patients that live in the middle of nowhere, and they've done their own rehab, and they've come back and they've had endurance issues and some cramping issues. So I really do think the PT is extremely important. And I think it makes the patient have responsibility. And if they know they're going to go see Adam on Monday, then do their home exercises, and they come in stiff, it's pretty evident. So again, I think PT not only gets you a better result, but kind of keeps you on track and maybe shortens your downtime a little bit. So everybody, I want to thank you very much. We will do this again. This is a great panel, very informative, and you guys have a great night. Thank you.